Welcome everyone to a discussion of interesting set of articles which are going to be published in this issue and the next issue of Neurogastroenterology and Motility Journal. My name is Dr. Purna Kashyap. I'm a gastroenterologist at Mayo Clinic in Rochester, Minnesota. It's my great pleasure to welcome Dr. Maura Corsetti. She's an associate professor in gastroenterology at the Nottingham Biomedical Research Center in the University of Nottingham in the United Kingdom. Maura leads the GI Motility Service, and she's the referral consultant for functional disorders of upper and lower GI tract at the Nottingham Digestive Disease Center. She'll discuss the two-part series on contemporary perspective and clinical challenges in constipation, which will be published in the June and July issue of Neurogastroenterology and Motility. Welcome, Maura, and thank you for taking the time to talk to us about these two articles.
Thank you very much. It's my pleasure.
Thanks. Before we get started, I haven't seen this kind of article before in Neurogastroenterology. So can you tell us, give me some background about this two-part series and what was the motivation behind developing this really interesting and practical series of articles?
So the initiative was launched by Mark Scott in London because in 2009 he organized a meeting that was titled Current Perspective in Chronic Constipation, and then in 2018 he decided to do a kind of update, so 10 years later, and then invite all the international speakers to really discuss all the issue around constipation. And so we then decided that this was a good opportunity to write these two reviews. One is mainly dedicated to the diagnosis, epidemiology, and pathophysiology, and the second one is dedicated to the treatment and what we know about the evidence-based behind the treatment.
Sorry, I should have realized. So that actually is great because that explains why the focus on constipation. Because it looks like it was a continuation of what you guys had done previously. But was there any specific reason that you focused on constipation again this time?
Yeah, definitely there is a reason. Well, normally constipation is considered kind of a minor problem, and people tend to underestimate this, while it affects quite a lot of people. So let's say that the global prevalence is around 14% in the general population. But just to give you some numbers, I was shocked when there was a publication of a report on cost of constipation in UK that actually demonstrated that 2 million people suffer from chronic constipation in UK. And 200 people are normally admitted to the hospital each day for constipation. And this brings to a cost for the UK healthcare system of, let's say, more than 160 million per year. And this includes more than 70 million of pounds just for unplanned admission. That is something that is quite huge cost if you consider that indeed constipation should be something that we are able to treat as an outpatient clinic, and normally we don't think that this requires admission. So this was kind of shocking for us, and so this is why it's so important to really get the clinician to really diagnose the patient in the proper way and then treat as effectively as we can.
That's actually both interesting and surprising, and that really, before I go to the next question, it brings to mind, do you think it's because people don't feel constipation is a disease and needs to be treated, and they wait till the very end to get treated for this?
Yes, I think that is both a problem probably from the clinician point of view, because normally there are not so many clinicians that are interested in really dealing with patients that suffer from constipation. So normally we think that constipation is just something that, okay, the patient can go and take some laxative in the pharmacy and sort the problem out, while the problem can be really affecting the quality of life of the patient. So yes, definitely is probably us as a clinician, but also the patient that normally, well, gets to the clinician when the situation is really, well, too difficult to handle by themselves. So both sides, I think.
So what are the common diagnostic dilemmas, and this also makes me wonder if that's what discourages some physicians, because constipation is associated with conditions like irritable bowel syndrome, but you also have functional constipation. Do you see these different entities associated with constipation as being distinct entities or more as a continuum?
So, well, I think that there are different opinions. I'm one of the people that think that actually they're probably different in some way. Probably the pathophysiology is not yet as clear as it could, but let me underline something. I think that indeed the problem is that when the patient comes to our office and report constipation, we normally don't ask them if together with constipation the patient is also suffering from abdominal pain, because of course, the presence of abdominal pain points in the direction of irritable bowel syndrome. And in my clinical experience, when the patient is a patient with irritable bowel syndrome and constipation, then the treatment is more difficult because you need to really handle both two symptoms, so the pain and constipation. And sometimes treating the constipation can make the pain worse. So finding a balance between these two treatment is sometimes really challenging. And I have also to say that is more frequent for clinicians to realize that IBS, irritable bowel syndrome, can be associated with diarrhea or alternating bowel habits, but they don't think so frequently that this is also associated with constipation. So IBS with constipation is not so yet recognized as an entity. This is my feeling. And definitely this is challenging for people.
So, that actually leads to our next question. These are entities which are related to constipation alone, but there are also conditions that are often accompanied by constipation. Can you sort of give us a brief overview of that? Because what's important is how does that affect your diagnostic work and treatment plan when considering those conditions?
So I think there are definitely different conditions that can be associated with constipation. And if we think to secondary causes like neurological disease, this is really something that normally can make the management of this patient more complicated. But nowadays, especially in UK, and I know that is the same, for example, in USA, the most important problem that we have in clinical practice is the fact that a lot of patients also use opioids. This is something that makes the situation really complicated because this patient don't want to stop the opioids, and we know that opioids are making the colon more lazy and more and the transit delayed. But we also know that in the long term, opioid can induce what is called paradoxical hyperalgesia, and therefore patients with irritable bowel syndrome and constipation have a double problem because they have the constipation that gets worse with the opioid, and also the pain that is also getting worse because of the long-term use of opioids. And this is a battle that in UK I'm really doing since my arrival in 2016, because I think that this is one of the major reasons, and can be that is one of the major reasons why the patient then end up also be admitted in the hospital, because the constipation become really difficult to treat in any way.
That's a great point. And as you mentioned that, I was thinking that opioids are obviously a commonly recognized cause for constipation, but there are a lot of other medications which cause constipation as a side effect, which oftentimes go unnoticed, and we may be trying to treat constipation without actually addressing those medications.
Yeah, it's true. This is totally true. And I think that one of the points that now I realize is that indeed, when we collect the clinical history of the patient, we should really look carefully at the concomitant medication, because it's not infrequent that when you receive a referral from another clinician, you don't have even the list of the medication. Is something that we probably do not consider enough. I totally agree with you. Definitely, this is something that we should really consider more.
Great, and so you said that this was sort of a follow-up, and it's almost been a decade. So I thought we talk about briefly maybe about the advances in our understanding of the pathophysiology of constipation over the past decade.
Yeah, so I think that is a bit from one side a little bit frustrating because we still don't know a lot about the pathophysiology of constipation, but definitely there have been some advances. And I think that if I have to select two of them, I think that for sure the evidence that are coming from the high resolution colonic manometry application in this patient is definitely bringing some novelties in this field, because well, we knew already in the past that this patient present less of this high amplitude propagating contraction that are the one that are really driving the mass movement in our colon. But now we know that this patient has also less of this retrograde contraction that are normally present in the sigmoid region, and then are those that normally bring all the content up to the transverse colon, where we need to normally distend the bowel to really induce the high amplitude propagating contraction. So I think that we are getting closer to understand a little bit better what can be the alterated colonic motor pattern that are associated with the constipation. And hopefully in the future, we have now some study going on, also applying the MRI in this patient, we will probably be able to understand if there is indeed a difference between the patient with irritable bowel syndrome and constipation and functional constipation patient. And the second interesting aspect, I think, is about the macrobiota. And here I have to mention a paper from the Mayo Clinic group, from Adil Barucha, that actually find out that it seems that is the macrobiota in the mucosa of the colon of this patient that can be different in patient with constipation as compared to the healthy subjects. So this is, I think, is just an initial observation, but means that in the future we will have probably to look more careful to the microbiota of this patient, and probably have larger groups, study larger number of patients, to really try to find out what is the role of the microbiota in this patient, which I think is very, very interesting.
Great. And, you know, we obviously realize that diagnostic testing and treatments usually lag behind the new advances in pathophysiology. But at this time, what are the recommendations from you for diagnostic testing in these patients with constipation?
So let me tell you that in the second review, we really focus on this, because I think that what we are missing at the moment is really a flowchart that guide the clinician to really how to diagnose this patient, starting really from the clinical history taking through the different tests that you can apply in this patient. And at the moment, the problem is that indeed, I think that the functional tests that we normally apply in this patient are not predictive of the response to treatment. So in this flowchart, we really decided that the place for this functional test comes after you have tried all the medical treatment, pharmacological treatment in this patient. And the reason is different reasons. One of the reasons, as I said, is because these tests do not predict the medical response. Second, because unfortunately they are not available in all the centers, so only the specialized center have this kind of functional test available. And also we need to start considering also the cost. I have to say that in UK this is a very sensitive problem at the moment, because we need indeed to consider what to propose to the patient, something that is indeed cost effective to really change our diagnosis. At the moment, I think that after you tried all the pharmacological treatment, as you can see in the flowchart, then you can really propose to the patient the anorectal manometry with the balloon expulsion test. And the balloon expulsion test is the one that has been demonstrated to be predictive of the response to biofeedback. So this is as indeed and should have a clinical role. And after that, then you can consider, of course, the transit time and the colonic transit time, but also the evaluation of the upper GI tract transit time, to really try to understand if indeed you need to suspect what is called colonic inertia in this patient, and you need to consider other more invasive treatment for the patient.
Great. Now that we have some of the diagnostic testing out of the way, what about management? Do you usually start with pharmacotherapy, or do you usually recommend behavioral and lifestyle changes initially? sort of what kind of lifestyle changes, if you consider those in the patients.
Yes, so in the second review, what we really did is really to try to collect all the evidence that we have about all the possible treatment, indeed starting from the behavioral one, the diet, and then the pharmacological treatment, to really try to give a summary, an evidence-based summary of what you should consider in this patient. And of course, the evidence about the behavioral treatment are good for some of them, and let's say the biofeedback, the pelvic biofeedback definitely has strong support in the literature. As regard to the diet, it's interesting that fibers are frequently considered by clinician an important aspect to really propose to the patient for the treatment, and this is certainly true for fibers like soluble fibers like psyllium, but the evidence are not so strong. And I have to tell you that indeed there is also a difference if you have a patient that presents already with pain, abdominal pain, discomfort and bloating. You need to be careful to really propose fibers, because of course they can make the situation even worse. So all this evidence have been reported, and after that, of course, you have the possible pharmacological treatment. And in this flowchart, we try really to summarize everything, also to give some idea of how long you need to try the different option before really going to the next one, and when you need to start considering the patient a refractory patient, because in the literature we still don't have a diagnosis, an internationally recognized diagnosis of what means a patient refractory to pharmacological or to pharmacological and behavioral treatments, when we need to go to the next step and consider for possible surgical option.
Great. So I think, you already touched on the lifestyle and the behavioral aspects and the pharmacological treatment. Of course, the flowchart provides a good overview of this. Is there any evidence for microbiome-based therapies for treatment?
So at the moment, the evidence, as we summarize again in the second review, are, let's say, still not so strong to propose this as a treatment for constipation. And what we find out, really revising the literature, is that in most of the cases, also all the evidence that we tend to refer to IBS with constipation is actually referred to the IBS patient as a group, not to specifically to the constipation. So we realize that definitely there is a gap in the research, in the literature, that needs to be filled to really try to understand if there is something that is specific for this subgroup of patient, as well as for the functional constipation patient.
Great. I obviously I don't want to go through the whole review because there's a lot of information in there, but you did recommend surgical intervention, and so that's an interesting area of when do you consider surgical intervention in these patients?
So we made this really clear that surgical intervention should be really the last resource in this patient, and we need to really be careful when we decide to really think about this option. And we put in our flowchart that when you arrive and when you start suspecting that the patient needs to have this kind of option, it's better to really bring the case to a multidisciplinary discussion, where you need to have, of course, a functional gastroenterologist or a neurogastroenterologist, as myself, a colorectal surgeon. You need to have also the psychology or psychiatry that need to address also and be sure that the patient is not really asking for a surgical operation that is not needed, and is not really looking for a solution of symptoms that are not going to be solved by a surgical operation. And of course, gynecologists, urologists, and all the specialties that need to really take this decision all together. We need to revise all the tests that the patient has, and really be careful that the patient understand that if we propose a surgical operation, we are aiming to treat the constipation, but this is not going to treat, for example, abdominal pain or bloating that are not really the target of the surgical operation. So this needs to be really clear in the mind of the patient, because of course it's easy for them to think that the surgical operation removing the colon will sort everything out and will improve the quality of life. Has also a lot of side effects that are now clear, because thanks to Charlie Knowles, they reviewed the literature in a previous systematic review, and we reported in this second review all the main results of this systematic review to really underline how many possible side effects are related and complications are related to the surgical operation. So only those patients that really need to be considered for this are indeed need a careful consideration indeed.
Great, and that's important to have that word of caution. But yeah. What do we have to look forward to in the next decade before you take out the next edition of contemporary management?
So I think that is interesting, because in both the two reviews we highlighted the area for research for the future, and they are specific for each part of the review. And I think that if I need to really select one, I think that we would need to really reevaluate indeed well, to perform a multidisciplinary trial in the future to really understand how to select the patient that needs to have surgical operation or not, and really to relate this to the possible predictivity of the test that we are performing to really predict the response to surgical operation. And this is something important, because still at the moment a lot of patients are referred for surgical operation and they don't need this, or they need the surgical operation and they are referred for the wrong one. So I think that this is one of the most urgent things that we need to do for the next future. And this was an occasion really to put together all the relevant people at international level that have really the possibility to drive this kind of future studies.
Great, and that actually does bring up the point that this is obviously a group effort. While you've come up with really good and practical advice as a part of these two reviews, if you wanted to give a big shout out to the whole group which put in this effort to develop these contemporary reviews.
Yes, so this was a really a nice experience, and I was mainly the lead of the second review, but I was of course involved also in the first one. And yes, they are international colleagues, like as I said, Charlie Knowles, colorectal surgeon. Then we have Magnus Simren for Sweden. We have then Anton Emmanuel from UK, Mark Fox from Switzerland. Giuseppe Chiarioni from Italy, so and Phil Dinning from Australia, from the colonic motility side. So I think that this was really an effort that was really a nice experience, because we really dedicated a lot of work to this review, and we put together the best evidence that we have at the moment. So if you want to read something that is pragmatic and really give a summary of what we know at the moment about chronic constipation, I think that these are the two reviews to read at the moment.
Great. We really appreciate you putting in this effort, and that was really a truly international group of people who came together to provide this practical and pragmatic approach which people can apply in their practice. So that I'd like to thank Dr. Maura Corsetti for the excellent reviews and assisting in the podcast this month. I also want to thank our reviewers for tuning in. I look forward to welcoming you again next month with another interesting set of articles. Thank you.
Thank you very much.
Thanks, Mark.